So coming to the most important part of this lecture is the diagnosis. How are we going to diagnose a patient who comes to the OPD having different types of pain, having different types of symptoms, and after examining the patient, how are we going to diagnose this patient? So there are a set of alarming features that are very necessary to rule out in patients with irritable bowel syndrome. These alarming features, they warrant a prompt investigation in the process. So these alarming features include, if we take the history, the patient might complain that he had blood in the stool, that the patient is having diarrhea for a very, very long time, having chronic diarrhea. And then this is very necessary to ask the patient if he has a family history of colon cancer, or the patient has a family history of inflammatory bowel disease or celiac disease. So these are the very necessary three diseases to rule out. And then we need to see if the patient has any fever, if the patient is an old age person above 50 years, if he has any fever, any nighttime symptoms, if the patient is also having an associated progressive dysphagia and vomiting, any short history of symptoms, and lastly travel history with weight loss. As you all know that there is diarrhea, so we need to rule out if the patient has any gastroenteritis, could be because of traveling to some remote areas. And then the physical examination could include abdominal mass, and then we could also see if the patient has any active arthritis. We need to have a skin examination. While having a general physical examination, we need to see if the patient has any dermatitis herpetiformis or any pyoderma gangrenosum. Any overt blood or rectal or mass within the rectal examination. So a rectal examination is also very, very necessary. This is one of the alarming features. Any signs of anemia, this could be because of the blood within the stool or any bleeding within the gastrointestinal tract. So this is also very alarming. Any signs of intestinal malabsorption, signs of intestinal obstruction, and lastly, any signs of thyroid dysfunction, as there could be an association, and the imbalance of the hormones could also be one of the reasons why a patient might be having diarrhea or constipation. As you all know that a patient with hypothyroidism could present with constipation, and a patient with hyperthyroidism could present with diarrhea. So it's very necessary to rule out any thyroid regarding disease. And then if we talk about the criteria, I've mentioned one of the most important criteria, which is the Rome criteria in the starting of the lecture. We have two other criteria, which is the Manning criteria. So the Manning and associates were first reported a set of symptoms that could have been could help us in diagnosing irritable bowel syndrome. So this list of symptoms includes the abdominal pain that is eased out after a bowel movement. So a patient, he has abdominal pain, and then when he rushes to the washroom and he releases his bowel movements, then he feels that the pain has been relieved. And then if we need to see if the patient has any looser stools at the onset of the abdominal pain. More frequent bowel movements at onset of abdominal pain, which is also one of those criteria with the Rome criteria. So this is also listed over here. Any sort of abdominal distension, we could see this with the examining the patient's abdomen. Mucus per rectum, we could ask the patient as if he has seen any mucus sort of consistency within his stool. And then feeling of incomplete emptying. This could be usually in patients with constipation. The patient, he goes to the washroom, and then after releasing his bowel movements, he feels that there is an incomplete emptying. So latest studies showed that these symptoms, they're usually we're very specific as compared to being sensitive for irritable bowel syndrome. And then coming to the next sort of a criteria, which is the Cruis criteria. This Cruis scoring system was based on the presence and the duration of the symptoms, and then also having negative physical examination findings and having completely normal lab reports. So if this all happens, we need to go through the scoring system of Cruis, which includes the patient's history. So the history points would be asking the patient if he has any abdominal pain, if he has any flatulence, if he has an irregularity of his bowel movements, they aren't on time. Symptoms that are persistent for more than 2 years. So this is very, very necessary. Mixed diarrhea and constipation, and then having pellet-like stools or mucus. Like I've mentioned before, the stool forms. Having pellet-like stool could be a symptom of having constipation type of an irritable bowel syndrome. And then we need to see the physical physician's assessment if after the patient has been examined thoroughly by the physician. We need to see if there's any abnormal physical findings. We need to check the ESR rate. So this is also very necessary to rule out any inflammatory bowel disease or any other intestinal disease. So we need to check the erythrocyte sedimentation rate, and it might be above 20 millimeter per 2 hour. Leukocytosis, if it's more than 10,000 centimeter cube. Hemoglobin, usually in female, if it's less than 12 grams per deciliter, and in males, having less than 14 grams per deciliter. And then having the history of blood and stool. So as you can see, it's a mixed picture of having anemia or having any other intestinal disease. So now if we come to the laboratory investigations, these are the most typical and traditional lab tests that we will be prescribing the patient with. A full blood count, which is the CBC, having a renal liver biochemical testing, RFTs, LFTs. It could be the thyroid function testing. Like I've mentioned before, having symptoms of constipation or diarrhea could confuse us a bit. Evaluation of 3 fresh stool samples. So this is very necessary to see if the patient has any worms or any blood within the stool. Hydrogen breath test could also be one of the tests that we could perform. Having an elevated C-reactive protein, and having an SEHCAT scan, which is the Selono 25 cholic acid testing. So this is also very necessary. And other than that, we could also perform a fecal calprotectin test. So these are the traditional tests that we could be performing in patients suspected of irritable bowel syndrome. So lastly, colonoscopy with biopsy is usually done in patients who have a chronic diarrhea. So a patient having diarrhea for a very, very long time, it's very necessary to rule out if the patient has any microscopic, any sort of a microscopic worms or any sort of disease. So we usually perform the colonoscopic procedure. The physician does it, and we also do it with biopsy so that we can take a sample of the lumen in case we suspect any inflammatory bowel disease. Other than that, we also perform some tests for constipation, which is the manometry of the intestine, and this is also very necessary in distinguishing and differentiating other diseases of intestinal tract.